because of technical issues. Basic concepts. The body systems act to maintain internal consistency. بالمناسبة هاي المحاضرة يعني تعنى بالاستجابة metabolic responses and the neuroendocrine responses to trauma and injury. Trauma also يعني the surgery included within the trauma. The body systems act to maintain internal consistency. Complex homeostatic responses involving the brain, nerves, heart, lungs, kidneys, and spleen work to maintain the body consistency. Responses to injury are in general beneficial to the host and allow healing and survival, which means that the response is not harmful at the all period, but can be beneficial to the host and allows the healing and survival. A normal healthy adult requires approximately 25 kilocalories per kg per day. A normal healthy adult requires approximately 25 calories. These calories can be derived from the carbohydrates, lipids, and protein, which means that three foodstuffs, we can get the calories from these. This requirement can be as high as 40 kilocalories per kg per day in severe stress states, such as those seen in patients with burn injury. That means the requirements will be increased in severe stress states. In short-term fasting, less than 5 days, the principal sources of fuel are derived from muscle protein and body fat, with the body fat being the most abundant source of energy, which means that the fat has the highest source of energy than the others, the carbohydrates and proteins. The normal adult body contains 300 to 400 grams of carbohydrates in the form of glycogen. Approximately 100 grams of which are stored in the liver, and 200 to 250 grams of glycogen are stored within skeletal, cardiac, and smooth muscle cells. It is important to recognize that the response to injury is graded. بمعنى أنه هي تتدرج الإصابة الاستجابة للإصابة. The more severe the injury, the greater the response. It means that it is proportional. The more severe the injury, the greater the response to it. This is not only applies to physiological or metabolic changes, but also to immunological changes and sequelae. Following elective surgery of intermediate severity, there may be transient and modest rise in temperature, heart rate, respiratory rate, energy expenditure, and peripheral white blood cell. Following major trauma and sepsis, these changes are accentuated. And these changes that there may be rise in temperature, heart rate, respiratory rate, energy expenditure, and peripheral white blood cell counts. These will be an increase in major trauma and sepsis. As we said, it is proportional to the severity of injury or trauma. These conditions will result in a systemic inflammatory response syndrome, marked catabolism, stroke, and even multiple organ dysfunction syndrome. What are the mediators of the metabolic response? The mediators of the metabolic response to injury, we have the classical neuroendocrine pathways of the stress response, which consists of afferent nociceptive neurons, the spinal cord, thalamus, hypothalamus, and pituitary. The natural response to injury includes the immobility and rest, anorexia, and catabolism. These are natural responses, two of them taken by the patient by immobilization of the injured part and have some rest of that part, and by anorexia. The catabolism of the tissues take place, which is a natural response to trauma and surgery. We have two phases which are called ebb and flow phases. يعني بالعربي يسموه المد والجزر، أطوار المد والجزر. يعني in response to the trauma and surgery, the response will take an ebb and flow pattern. The ebb phase begins at the time of injury and lasts for approximately 24 to 48 hours. It may be attenuated by proper resuscitation. يعني we can reduce this ebb phase by proper resuscitation of the patient, but not completely abolished. We cannot abolish it completely, but partial abolition. The ebb phase is characterized by hypovolemia, decreased basal metabolic rate, reduced cardiac output, hypothermia, and lactic acidosis. The predominant hormones regulating the ebb phase are catecholamines, cortisol, and aldosterone. These are the characteristics of the ebb phase: hypovolemia, decreased basal metabolic rate, reduced cardiac output, hypothermia, and lactic acidosis. The predominant hormones which are regulating this phase here of importance are the catecholamines, cortisol, and aldosterone. Magnitude of this neuroendocrine response depends on the degree of blood loss and the stimulation of somatic afferent nerves at the site of injury. For these two factors, the stimulation of somatic afferent nerves and the degree of blood loss, which means the hypovolemia, that lead to the magnitude of the neuroendocrine response. Following resuscitation, the ebb phase evolved into a hypermetabolic flow phase. After we resuscitate the patient, this ebb phase will change into a hypermetabolic flow phase, which corresponds to the systemic inflammatory response syndrome. This phase involves the mobilization of body energy stores for recovery and repair, and the subsequent replacement of lost or damaged tissues. It is characterized by tissue edema, increased basal metabolic rate, increased cardiac output, raised body temperature, leukocytosis, increased oxygen consumption, and increased gluconeogenesis. The ebb phase will take hours, characterized by shock, and the flow phase will be prolonged for days, And this, as we said, it is characterized by catabolism, and the energy source are broad, and the recovery will take weeks, which is the period taken for anabolism. During the catabolic phase, the increased production of counter-regulatory hormones. These are important hormones which we are called the counter-regulatory hormones. These are the catecholamines, cortisol, insulin, and glucagon, and also an inflammatory cytokines, as you may hear about, which is the interleukin 1, interleukin 6, and tissue necrosis factor alpha, which results in a significant fat and protein mobilization, leading to significant weight loss and increased urinary nitrogen excretion. The counter-regulatory hormones and the inflammatory cytokines plays the important role in the fat and the protein mobilization for energy expenditure. Increased insulin at this time is associated with significant insulin resistance, lead to poor glycemic control, leading to increased risk of complications, particularly infectious and cardiovascular. What is the purpose of neuroendocrine changes following injury? First, to provide essential substrates for survival. It can postpone anabolism and optimize host defense. These are the purpose of neuroendocrine changes following injury. It provides the essential substrates for survival, postpone anabolism, and optimize host defense. These changes may be helpful in the short term. In the short term, these changes may be helpful, but may be harmful in the long term, especially to the severely injured patient who would otherwise not have survived without medical intervention. And without medical intervention, the patient may lose his life if these changes can be in the long term, unless it is reversal by medical intervention. During the response to injury, not all tissues are catabolic, which means that some tissues are catabolic, some tissues in a constant state. That is to allow the body to reprioritize limited sources away from peripheral tissues. The peripheral tissues like the muscle, adipose tissue, and the skin have limited resources. And towards the key viscera, which means that the response, the catabolism occur at the key viscera, liver, immune system, and the wound itself. The majority of trauma patients, except those with extensive burn, demonstrate energy expenditure approximately 15 to 25% above predicted healthy resting values. Patient energy expenditure could rise even higher than observed levels following surgery or trauma, but several features of standard intensive care, including bed rest, paralysis, ventilation, and external temperature regulation, counteract the hypermetabolic driving forces of the stress response. The skeletal muscles wasting experienced by patients with prolonged catabolism actually limits the volume of metabolically active tissues. We can, by these methods, counteract the hypermetabolic driving force of the stress response. What are the measures? Bed rest, paralysis, limit the movement of the patient, Ventilation and external temperature regulation can counteract the hypermetabolic driving forces of the stress response. The skeletal muscles wasting experienced by patients with a prolonged catabolism actually limits the volume of metabolically active tissues. During the catabolic phase of the stress response, muscle wasting occurs as a result of an increase in muscle protein degradation, coupled with decrease in muscle protein synthesis. Cardiac muscle appear to be mostly spared. Of these muscles, degradation of the muscles, the cardiac muscle appear to be spared. Under extreme conditions of catabolism, like in case of major sepsis, the urinary nitrogen loss can reach 40 to 20 grams per day, which equal 500 grams of skeletal muscle per day, which means that there will be a muscle wasting and the patient will lose weight. Clinically, a patient with a skeletal muscle wasting will experience asthenia. If skeletal muscle wasting happened, the patient will experience asthenia, increased fatigue, decreased functional ability, decreased quality of life, and increased risk of morbidity and mortality. In response to inflammatory conditions, including surgery, trauma, sepsis, cancer, or autoimmune conditions, circulating peripheral blood mononuclear cells secrete a range of pro-inflammatory cytokines, which include interleukin 1 and 6 and tumor necrosis factor alpha. These cytokines promote the hepatic synthesis of positive acute phase proteins like fibrinogen and C-reactive protein. And the albumin will fall acutely following the injury. But these cytokines, interleukin 1, 6, and tumor necrosis factor alpha, promote the hepatic synthesis of acute phase proteins, fibrinogen, and C-reactive protein. Insulin resistance. Following surgery or trauma, the post-operative hyperglycemia, this means that post-operatively, there will be a state of hyperglycemia because of insulin resistance. And also from the mobilization of glycogen in the liver, this will result in hyperglycemia, and mobilization of protein and fat lead to a new state of development of a new sugar, lead to hyperglycemia also, will develop as a result of an increased glucose production, which means gluconeogenesis. This increased glucose production combined with decreased glucose uptake in the peripheral tissues as a result of insulin resistance. This condition will, because of mobilization of glycogen stores and fat and protein, lead to new glucogenesis or gluconeogenesis. This will increase glucose in the peripheral blood and tissues, combined with insulin resistance, will lead to a state of hyperglycemia. The degree of insulin resistance is proportional to the magnitude of injurious process. And as much as the severity of the injury increases, there will be an increase in the insulin resistance. Post-operative patients with insulin resistance behave in a similar manner to individuals with type 2 diabetes mellitus and are at increased risk of sepsis, deteriorating renal function, polyneuropathy, and death. What are the changes in body composition following injury? A normal human normally ingests about 70 to 100 gram protein per day, which is metabolized and excreted in urine as ammonia and urea, which approximately 14 gram nitrogen per day. Following major injury, there is continuing urinary nitrogen losses of 10 to 20 gram nitrogen per day, equivalent to 500 gram of weight lean tissue per day. Critically ill patients admitted to the ICU with severe sepsis or major blunt trauma undergo massive changes in body composition. Body weight increases immediately on resuscitation with an expansion of extracellular water by 6 to 10 liters within 24 hours. This will lead also after resuscitation to tissue edema. Thereafter, total body protein will diminish by 15% in the next 10 days, and the body weight will reach negative balance. This can be achieved by blocking neuroendocrine stress response with analgesia. يعني احنا نقدر نسوي reversal of this breakdown of protein and negative balance by giving the patient analgesia and providing early enteral feeding. يعني as fast as the patient can return to the normal enteral feeding, can also reverse this response. With avoidance of excessive administration of IV saline. And we should avoid the excessive resuscitation. The metabolic stress response may be further exacerbated by anesthesia. Anesthesia also is a stress response that will lead to exacerbate the metabolic stress. Dehydration is also another factor that exacerbates the metabolic stress response. Starvation, which include the pre-op fasting. As much as the preoperative fasting increased, the metabolic stress response to the surgery will also increase. Sepsis is also one of the factors that exacerbate the metabolic stress response. An acute medical illness, like for example, the patient have a cardiac problem, or he have uncontrolled diabetes mellitus or uremia, can also exacerbate the metabolic stress response. Even severe psychological stress can have an impact on the metabolic stress response. What are the avoidable factors that compound the response to injury? We have factors which can be avoided, like the continuing hemorrhage. Continuing hemorrhage can be managed by stopping the bleeding vessel or vessels. Hypothermia is also can be avoidable. The hypothermia results in increased elaboration of adrenal steroids and catecholamines. It also results in 2 to 3 folds increase in post-operative cardiac arrhythmias and increased catabolism. Tissue edema, tissue under perfusion, starvation, and immobility. These are avoidable factors: continuing hemorrhage, hypothermia, tissue edema, tissue under perfusion, starvation, and immobility. All these factors can be avoided to reduce the response to injury. I think this is the last slide of the lecture. How we can prevent unnecessary aspect of the surgical stress response. Now, during surgery, what are the preventive measures that we can undertake to reduce the surgical stress response? Try to use minimal access techniques, and the widespread use of laparoscopic and endoscopic surgeries can have a beneficial effect on the reducing surgical stress response. Blockage of afferent painful stimuli by giving strong analgesia, and minimal periods of starvation. We should minimize the periods of starvation before surgery, and also the early mobilization post-operatively can also have a beneficial impact on the surgical stress response.